So my work here is short. I'm just going to give a snap overview of a study that we did looking at implementation of the Choosing Wisely in Africa. We looked at 3 countries, Rwanda, Ghana, and Tanzania. At Rwanda, we looked at the Rwanda Military Hospital, the cancer center, and at the Kobu Teaching Hospital in Ghana. And in Tanzania, we looked at Ocean Road Cancer Institute and Muhimbili National Hospital. So declaration of conflict of interest. In Tanzania, there were 2, because I work at Muhimbili National Hospital, so it had to be included. Yeah. So by now, we all know what are the Choosing Wisely initiative. And we all agree that the aim is to minimize overuse in cancer care. This initiative encourages a conversation which is aimed at avoiding inappropriate utilization of resources through minimizing prescriptions that are considered invaluable, unnecessary, and at times harmful to the patients that we see. So not to repeat what Dr. Fidel has mentioned, in 2010 there were 10 recommendations given, and these were given by a task force driven by oncologists working within the continent. But for our study, we only looked at 5 because we wanted to evaluate how is the concordance to these recommendations in the management of breast cancer. So we evaluated the use of multidisciplinary tumor boards discussion in treatment planning, staging before treatment is given, and also discussion on the treatment before it is given involving the patients. And also if any lumpectomy or surgery was done before histology confirmation of the malignancy, and the use of single agent in metastatic setting, rather combination, unless indicated, and if the evidence supports shorter radiation treatment, was this the course given or longer ones were preferred? So we had a total of 542 participants. The median age in these 3 countries was around 49 years, ranging from 20 years all the way to 98 years. And we all know breast cancer is predominantly higher in the female population, and this was also the finding, with 97.4% of all the participants that were female. And in terms of the 3 countries, Ghana represented around 37% of the study participants there were assessed, and the results that we are presenting here. So first thing we looked at was the health insurance in terms of the cost. And because we saw cost benefit is looking at both from the equation that Fidel gave in terms of what you give and also minimizing the harm. So we noted that we had a higher health insurance coverage in these 4 institutions. It was around 51.9%. And further analyzing this insurance, 55.35% were private, and national was 44.65%. We had around nearly 50 or 48.9 of the patients that were receiving care did not have health insurance, hence we are paying out of pocket. In terms of staging, most of the patients presented with stage 3 disease. That was around 40.8%. Stage 1 disease was only 5.9%. And looking at most studies in Africa, this is in line with that. Most of the patients are presenting in late stage. In terms of treatment planning before having a multidisciplinary tumor board, Rwanda had 100% multidisciplinary discussion in patients before treatment is given. From the 10 recommendation, it was rather if curative intent is the plan, then it should have a multidisciplinary tumor board. But the setting in Rwanda, utilizing the collaborations and the workforce they have, all the patients, whether curative intent or palliative intent, they are discussed in the multidisciplinary tumor boards. Tanzania, it was around 72.8%, and in Ghana, it was 8%. Staging was the disease stage before treatment in terms of radiology. This coverage was also highest in Rwanda, and in Ghana it was 100%, and in Tanzania it was Most of the common modalities used for looking at the disease extent was chest X-ray and ultrasound. A few centers did CT scan. MRI was low to none. And yeah, but unfortunately, some of the patients actually received treatment before disease extension was done or confirmed radiologically. And this was more so in Tanzania, with having around 11.9%. In terms of doing surgery before a confirmation histologically of a malignancy, most of the patients did get staging done did get confirmation done before the surgery was done, which was 91.2%, but we had 8.8% that surgery was done without having a histology confirming it was malignancy. And in terms of immunohistochemistry, in terms of pathology, infiltrating ductal carcinoma was the most prevalent, covering around 74.5% of all the pathologically diagnosed breast cancers in these 3 countries. And now we look at, in terms of using a single agent chemotherapy in a metastatic setting. So patients with metastasis using single agent, this was more of a common practice in Tanzania with 52.6%. And in Rwanda, it was, they preferred more using combination therapy. And in terms of radiation, using conventional or hypofractionated or shorter courses, this was also noted in Tanzania, where shorter radiation courses was preferred with around 69.9%. But with Rwanda, most of the radiation use was conventional. So this actually, you can assess this in terms of the socioeconomic status and the distribution of patients within the 3 countries. And that's why you can see there is some variation in terms of the population they are seeing and the practices in the countries. But from this short snapshot, what could we conclude? There exists diverse approaches to treatment across the countries, but there is room to increase concordance to the CWAs. One thing is the prevalence of multidisciplinary tumor board discussion, which is 100% in Rwanda, and also adherence to staging guidelines. These prove there is evidence-based and patient-centered care in these centers. The insurance coverage and breast lump removal without histology confirmation highlights areas for improvement. The need for us to standardize the practices in order to improve healthcare accessibility. So these results overall, they informed on the healthcare stakeholders and policymakers that as a region, we need to align our practices, because we all remember that the CWA initiatives or recommendations were made by a task force within Africa. So if we all agree with the objectives, then we should align our practices to meet them, because the ultimate goal is to enhance the quality and the outcome of cancer care that we give. Thank you very much.